Unlike some of the other speakers in, I think, the other room, now how do we get this going?
Come. We can see your slides, sir.
Ah, okay. Okay. Thank you. Thank you again, organizers, Manoj and Banshibai, for inviting me and for the very interesting format of this evening's talk. I think the idea was for me to actually just give a little bit about how maybe people elsewhere might look at this business of putting CGMs into hospital. And I think it's one of those things where everybody understands that this is desirable, but the devil is in the details. How are you going to actually do it? So I think some of the considerations for using CGMs in hospitals is what's the site and nature of the intended use? What's the setting? Who will use the data? What's the purpose? And who provides the equipment? Is it the patient walking in, or is it hospital equipment? While standard for outpatients, CGMS use in hospitals remains largely off-label in many parts of the world, although in the US it became widely adopted during the coronavirus epidemic. Despite between device and settings related variability, current CGM devices do show reasonable accuracy, with MARDs ranging from about 10 to 23%. But I think one of the big issues is that the MARD thresholds for safe in-hospital CGM use without confirmatory POC testing and evidence-based protocols for CGM applications in ICU and non-ICU settings are not yet established. I think many places do use it, but with local caveats. For example, my neonatology colleagues will not use it in children below 2 kilograms. There is a lag time between glucose values in capillary and venous blood, and while a brand of sensor can claim to be very accurate based on MARD ratings, individual sensors can give inaccurate results. There can be patient factors. Other speakers have talked about this. And all current commercial CGMS systems have an appreciable failure rate and may give inaccurate readings from time to time. However, some systems are more likely to fail than others and more likely to give inaccurate readings than others as a design feature. So all staff must be aware of the benefits and pitfalls of CGMSs. And then the question is, do you buy the same brand for your ICU or for your general wards? Do you accept that patients walk in with their own CGM? So there needs to be a formal policy regarding the use of CGMs in all hospitals, and you need to review this very regularly as the technology matures. So are we talking about a standalone CGM, which is a continuation of personal device use, or are we talking about the new patient, newly diagnosed, and newly onboarding a CGM in hospital, or an insulin pump user with his own hybrid system and he wants to continue with his own system? Or are we talking about clinician-initiated use for close monitoring in the ward, in the OT, in the ICU setting, where it's a hospital that has provided the equipment? So what needs to be set in place is clear policy communicated and taught to all staff about what to do when CGMS readings suggest an actionable value. And at this time, I think around the world, the safest recommendation is to confirm the reading with a finger prick glucose if the reading shows an actionable level, or for that matter, maybe actual blood glucose sent to the lab. So there are various criteria that people have set out for when you might actually want to do a confirmatory finger prick. But for any hospital that wants to implement a new CGMS system in hospital, I think step-by-step implementation needs to be looked at. Site-specific practices and protocols need to be set in place. There has to be workflows. There has to be training and refresher courses. You have to figure out what happens every 3 or 4 months when the new house officers and the new resident doctors come in. You need to think in terms of patient selection and who cannot be put on a CGMS at this point. Should you include this data in electronic health records? How are you going to do that? And how are we going to do the quality control? You also have to anticipate bad batches, bad sensors, bad patients, anticipate earlier failure and drop-off. What do you do? How do you report? Who replaces this? whose money is it that is spent if a new sensor needs to be used, and if a whole batch of sensors seems to be giving funny values, who does the adverse event reporting? So you need to establish actionable levels for each hospital and care setting. And as my previous speaker has said, the different societies have decided on different priorities, different actionable levels, different site-specific levels for action. And we could actually be looking at AI, but AI really depends on the quality of the data going in. But certainly help in figuring out what to do would come next, right? So I think there have to be certain things that you have to teach hospitals and what we call equipment acquisition committees about what to do and how to evaluate new systems. In Singapore, we had a little bit of fear among the doctors when new systems were actually introduced on the market, because we have a very strong value-based, value for money-based system. The question is, were these new, cheaper systems going to be up to the mark? So that's not to say that some other places have not managed to successfully input CGMS into the hospital systems, and we should learn from them. And I would just say that if there's anything, there's one overview slide I would have that seems to sum it all up. You need to have a system in place. Somebody needs to be able to keep relooking at the system, and you cannot let this be done by people who actually do not understand CGMS systems. You have to have some wise old birds among the physicians to actually lead this charge. Thank you very much.
Thank you very much.